Good afternoon, everybody. I'd like to welcome all of you to our next session of the APDR National Virtual Noon Conference. We're in week 12. My name is Dr. Hart Beatty. I'm the chair of the Education Committee for the APDR and the Neuroradiology Fellowship Director at Boston Medical Center, and I'd like to welcome you to this session. Very excited to have two, again, amazing speakers as we've had throughout the series. Just a few housekeeping items. As you all know, the webinar is being recorded and it is being hosted on the APDR YouTube channel to be viewed anytime. As attendees, your microphones are muted to ensure optimal quality. And if you do have questions for our presenters, we ask that you use the question and answer tool in the Zoom platform. And if our speakers can get to it during the session, that's great. If not, then they've been great about emailing you responses after the fact. But let's get going here with our session for the day. It's really a great pleasure for me. I consider both speakers dear friends, in addition to leaders in the field and really wonderful people. First, David Rosman. He's the president of the Massachusetts Medical Society and in the Division of Abdominal and Interventional Radiology at Mass General. He's going to be speaking on esophagus, what goes down might come up. And Jessica Robbins, Associate Professor of Radiology, Vice Chair of Faculty Development and Enrichment at the University of Wisconsin. Today, Jessica will be speaking in the second session on cervical cancer diagnosis and staging, treatment planning, and post-treatment monitoring. So without further ado, I'd like to invite Dr. Rosman to begin his presentation. I'll stop sharing my screen and if you'd like to take over.
Perfect. I'd be happy to. Thank you so much, Harp. I very much appreciate it. Here we go. Well, thank you, everybody. Good morning to those who are west of me. Good afternoon to those on the East Coast. And I guess there are people who go further east, and then it could be good evening as well across the pond. So the esophagus. We're going to start off with some fluoroscopy here. And, you know, in truth, there's a lot to be done still in fluoro, although it's changed over time. We do an awful lot still with the esophagus, and it's worthy to take a look. So I first want to thank my mentor, Frank Schultz. He's at the Leahy Clinic in Burlington, and some of these slides came just everything I know in fluoroscopy comes from him, and then as well some slides from Dr. Mike Shortsleeve out at Mount Auburn. So when doing a swallow, you know, the money is at the GE junction, and it's worth knowing exactly what you're looking at here. So we see all sorts of rings and compressions on the esophagus and at the GE junction, and knowing what they are is pretty important. So there's the A ring, and that's the junction of the tubular esophagus to the phrenic ampulla, and it's changeable. And you can see in these two slides that here there isn't a ring, here it is, and that's because it's muscular and it changes and actually isn't much of a ring at all that matters. It's just that transition from tubular to phrenic. What matters is the B ring, and the B ring is something that you do want to take a careful look at, and it's the junction of the squamocolumnar junction. So the squamous epithelium of the esophagus with the columnar epithelium of the stomach. And the B ring signifies that junction, and so as you can imagine, anywhere where you've got that change in the cellular structure is where a lot of pathology can occur. The C ring is the diaphragm, and it's also important to note that even at the C ring here at the diaphragm, you'll notice a little bit of haustral markings going up above the above the diaphragm, and so that isn't a hiatal hernia. It's simply the gastric folds going up above in the normal amount at the diaphragm. So the B ring can be represented a separate way, which in single contrast, it's the B ring. In a double contrast image, it's the Z line. And here, you know, if you don't always get these pictures of your distal esophagus, it might look like pathology, but it's not. That's actually just the difference of the appearance of squamous epithelium and columnar epithelium, and is represented by the Z line. So the Z line and then the B ring, and then you can see up here, this would be what is the A ring at the junction of the tubular and phrenic ampulla. So we then end up with examples of pathology when thinking about the B ring. And it can look different in a whole lot of ways. One, it can be too narrow. It can be too high. and it can be too wide in a craniocaudal dimension. And so here are all different pictures of an abnormal B ring for a few different reasons. And so this one here, you can see, is narrow enough that a 13 millimeter pill isn't going to get through it. That is probably true as well here, but it's clearly irregular, and you can see a little bits of contrast out here from the irregularity of it. And then the other thing is, you when you look and you see, well, here's the C, and you don't have folds going up above, that this is not a hiatal hernia, it's just a high B ring. And when you have a high B ring and you've got a movement of the B ring, you have Barrett's esophagus. And so we can see by looking at the B ring, you can end up finding an awful lot of pathology. So here we've got a Schottky ring. This is a Schottky as well, but there's more that goes wrong with this than just Schottky. This is sort of a pure Schottky. All you have is it's thickened, it is narrowed, but you have additional sets of pathology that goes alongside. So here's Schottky. And here are another couple examples of what I was referring to in the earlier image, which is an elevated B ring. So when you see the B ring go north, right, and you're expecting it to be pretty close to the C ring, within a couple of centimeters, and here it's quite obviously not. You see multiple vertebral bodies, right? So it's several centimeters away. This, but it's not too narrow, right? A pill would go through this just fine. So it's not Schottky, but it's elevated. And so when it's elevated, what does that happen? Well, the B ring, as we know, it shows you the junction of this squamocolumnar junction, and if it's elevated, that means that we are seeing squamous columnar epithelium migrate north. And so what we've got is metaplasia. And when you've got some squamocolumnar metaplasia, you've got Barrett's esophagus, and that's exactly what's happening here. Now, in Barrett's, you can end up with a lot of different things, right? So in other words, you might see a scope, and the scope said Barrett's, and your exam looks normal. And that can happen. So Barrett's can look normal. Barrett's can look strictured. It can be ulcerated. It can have a high ring, as I just demonstrated. And about metaplasia. And so here's an ulcer. You can also see that there's a pretty lengthy stricture. And so Barrett's has very many faces, but I will say that the ones where my residents most commonly will end up missing it, we'll all miss it in normal because that's what it looks like, but when is in the high B ring. And so keep an eye out for that. And if you've got a B ring that is substantially more than vertebral body above the C ring, then you should be suspicious for Barrett's esophagus. Remember, when we think about a esophagram in general, our job should be much more sensitivity than specificity. I would much rather recommend the scope on a case that turns out to have been normal than not have recommended it and miss something important. So what do we see here? And what do we think about? Well, there's a stricture, right? And so if you've got a stricture, and where are we? We're in the mid-upper esophagus. What is the differential diagnosis for a stricture in this setting? Well, there's a lot, right? It can be cancer, primary metastatic cancer, and I think normally when people see strictures, they think about cancer first. Now, there are a lot of other things, though, right? Radiation, anywhere up in the upper mediastinum, is a location for radiation, and that certainly can cause stricture, and we have some nice examples of that later. Ingestion, caustic ingestion certainly plays a role. Barrett's strictures do happen up high. I think we often think about Barrett's strictures as just at the GE junction. That is not true. Barrett's esophagus and Barrett's strictures can happen in the mid and upper esophagus as well. And this is one that I think is really important to think about, which is eosinophilic esophagitis. And I'll show you more pictures of this during the talk because it has, and we'll hit it, it's particularly important because it's friable mucosa. And friable mucosa indicates that they could really tear it during an esophagram, during a scope. And so you want to warn the endoscopist of that ahead of time. And then just because we all take boards and we need to be able to think of the less common things, pemphigus and pemphigoid, epidermolysis bullosa, but all of the bullous dermatoses can cause mid and upper esophageal strictures. So when you see this one, you wonder, is this a stricture as well? But then realize that there's external pressure here and an external force here, and that it's going in a direction. And then as we back up, you can see a little bit better that there's clearly a directionality to this. It's not internal, but it's extrinsic compression on the esophagus heading directionally. And then we can see here on the recurrent subclavian. So here's the aberrant right subclavian artery, comes across, causes that external compression, and you can see on the CT how it presses on the esophagus in this external way. Here we are pressing on the esophagus, causing that deformation. So you want to look sort of for the wide, smooth, obtuse impression from the external compression. Here's something that we see all the time, and you might see it so much that you end up not commenting on it, but it's actually worthy of comment. So what is this? This is the aortic arch, and it's taking this sort of Pac-Man bite out of the esophagus. Not taking a bite at all, of course. It's simply an external compression. But the external compression is real. So this patient complains about dysphagia. And, when people leave our imaging suite, I'll talk to them, and I'll talk to them about what it is that we've seen on their exam. And, when they leave and the answer is it's normal, they're usually happy and disappointed simultaneously, because there's something that has made them come to get our imaging. And part of it is the fear, but part of it is looking for an explanation. And, it's normal is usually good, because a lot of the answers that we give is it's cancer, and they don't want that answer either. But if you can give them a benign explanation for why they have their dysphagia, that's pretty helpful too. And so if the patient says, I've got dysphagia, or if they say, I have trouble swallowing, or the food won't go down, or it feels like it gets stuck, and then you see this, and then you even see the pill get held up there, because the pill will get held up here very often, then you have an explanation, right? So this is dysphagia aortica. Happens more in elderly patients. Kyphosis can create this as well, and then tortuous or dilated aorta. But importantly, mentioning it in your report is valuable, not because it's the most important diagnosis in the world, but because now the patient can stop getting a further workup because they actually have an answer. So this is feline esophagus. From spasm muscularis mucosa and the result of superficial esophagitis. Now, some people will say that feline esophagus doesn't actually have a meaning, that it's spontaneous, and that it is not correlated with esophagitis. I am of the other camp that believes that it is, and that it is caused by irritation of the esophagus, and that light level of irritation causes these feline folds. And I will tell you that if you work hard to get reflux, illicit reflux in your examination on a patient who has feline esophagus, you will almost always be able to elicit the reflux. It is not called feline esophagus because cats are striped, but not even the Tiger King. I should have changed that picture to a Tiger King picture. But at this point, it's called feline esophagus because cats actually have cartilage going down the length of their esophagus, causing this sort of appearance, although I've never done a swallow on a cat to prove it. I've just been told that. So here they are. What's important is that they are changeable, right? That it's here and then it's not. If it is persistent and it is always there and you can't get it to go away, that's not feline folds. That's something different. Right. Another word for this is esophageal shiver, and I think that's a good way to think about it in that it's transient. Here is a look that is related but different, right? So these are folds that you might confuse for feline esophagus, but you can see, and this looks like a corrugated esophagus, and nobody does washing by hand anymore on a piece of corrugated metal, but that is what this looks like, right? That bumpy metal that you could scrub something on, and for a corrugated esophagus. And this is another example of eosinophilic esophagitis. And so you'll see this again, eosinophilic esophagitis. This is the classic, is the corrugated esophagus, although again, as I said, there are a lot of faces to eosinophilic esophagitis. Here, it's more often men than women. They're young, and importantly, as I mentioned, they're fragile and prone to endoscopic tear. And so making the diagnosis of eosinophilic esophagitis, even if it's in your differential, is important to do in order to save the patient some significant morbidity from a scope in which they can be torn. So more examples of eosinophilic esophagitis, some gross pictures as well of these esophageal rings from the corrugation, and then you can see in these there's stricture and corrugation. So here's another 28-year-old male, dysphagia for months, pain after endoscopy, and there's the pill and it gets stuck. And you might think, well, it's getting stuck secondary to just the aorta, because that is a spot where normally a pill can get stuck. It's a little bit low, but then you see the rest of the esophagus, and the rest of the esophagus is quite narrowed. This is a long stricture from eosinophilic esophagitis. So a long stricture, this one is eosinophilic esophagitis, but very much like my earlier point of the upper and mid stricture, caustic ingestion, reflux or bulimia, Crohn's disease, and prolonged NG tube certainly can go along the length. Here are more, another long stricture, and you can see the transition that you go from a normal appearing and then a long stricture along the rest, right? So this is pretty good for caustic ingestion. Metastasis can do this with serous metastasis. Basically anything that could give you linitis plastica could similarly do this to your esophagus. So breast cancer is a good example of cancer that would be able to do this. Mediastinitis and tuberculosis, you'll often have other findings that will go along with that, but nevertheless that is certainly in the differential here. And then as mentioned, reflux and bulimia. Crohn's can do anything in eosinophilic esophagitis we have mentioned. A lot of the diseases as well that will have a long effect on the esophagus can have effects on the antrum of the stomach, and caustic ingestion is a particular one there, Crohn's, because it can affect multiple parts. So here we see sort of a next phase here, these diverticuli, and these diverticuli are traction diverticuli, and you can see you will often get the happy eye syndrome. You find one thing and you're satisfied and you feel like you've seen enough, but if you just look around the film, you will see something more. And here we have some calcifications in the mediastinum that help us make an understanding of what is causing these traction diverticula. So traction diverticula are caused by mediastinal inflammatory change, and here tuberculosis or histoplasmosis, something that is causing these chronic changes and chronic calcifications within the mediastinum, can similarly be causing these diverticuli. This is a different type of diverticulum altogether, right? It's no longer in the mediastinum. It's right at the GE junction and in the epiphrenic region, and this is an epiphrenic diverticulum. This is a different pathophysiology than the traction diverticulum. The traction diverticulum is pulled out by adjacent inflammatory change. This is a pulsion diverticulum caused by pressure. And the problem and spastic motility disorders. And so, the problem about these is that they can blow out, right? And so heaving or other causes of increased sort of valsalva and intrathoracic pressure, intra-abdominal pressure can cause this thing to explode. And then there's quite a bit of morbidity and mortality to that. And so when you see an epiphrenic pulsion diverticulum, you really do want to make sure that, the referring doc is aware because these often need to be repaired. So here's a finding that is just one of those minis. It looks like diverticuli, so I put it into the diverticular portion of the talk, right? So the traction diverticuli, the pulsion diverticuli, and these, but they are not regular diverticuli, right? These are pseudo-diverticula. They're intramural pseudo-diverticula, and what they actually are dilated intramural glands. They are usually evidence of past episodes of esophagitis. They are not terribly common. We don't see this very often, but important to know about them. And then these much more related to the the traction diverticulae are these, the post-inflammatory diverticula, which are really from re-epithelialized ulcer scars. They're usually associated with a stricture. They're above the HH because that's how they got the stricture in the first place, from a scar from reflux or Barrett's. Or if they are up high, then it's for all of the reasons why we talk about stricture up high, which is pills and caustic disease, bullous dermatoses. You can have them as well from a tear. Somebody had eosinophilic esophagitis, might get torn and have a scar, etc. So now we move on to something that looks quite different, and you see this enormous air fluid level within the upper chest, and then which at first I suppose could be a variety of things, including the abscess that would have this patient bedridden and in huge problems, or a huge bleed into something. But of course we can see what's happening in the rest, which is this big dilated esophagus. And so then we know that this is a megaesophagus from achalasia. Could it be a megaesophagus from other sorts of stricture, like a cancer stricture? Probably not. For it to get this big and the patient has cancer, the cancer probably would have killed the patient. From scleroderma, that is certainly possible. We will definitely see dilated esophagus in the setting of scleroderma, although less commonly. We mostly just see what looks like an esophagram that looks like the best esophagram you've ever done, and it's because they've got a non-contractile esophagus. Chagas disease, I put on this mostly for the differential, or depending on where you are witnessing this, it is possible where Chagas is more likely to occur here in the Northeast in the U.S., not so much. So here we see a stricture, and the differential for this is going to be cancer versus achalasia. And then as we wait some time, it opens up. And that helps us answer the question, right? That means it's achalasia, right? Cancer isn't going to change like that. Now, what I don't want you doing is seeing this, see it open up, and then say, therefore, I know that it's never going to be cancer. You can get... it may be that what it is it's overall narrowed because of the cancer, and then there was simultaneously the GE junction was closed down and contracted, and therefore it remains narrowed. Achalasia is diagnosis eventually that you need to make sure that you do a scope and some manometry in order to get this right. But it is the case that achalasia is changeable. It does open up, and that when you see this is much more likely to be achalasia than it is to be cancer. So here are some other examples. This is an achalasia case. It closes, but it does open up eventually. And then this one, as well as an achalasia, this one is a cancer. Cancer as well. So there's achalasia and pseudoachalasia, and ultimately, again, you're going to want to be able to do the scope. So here's another sort of muscular problem with the esophagus, and this is the corkscrew esophagus. We see all variants on this of tertiary contractions and various types of dysmotility and presbyesophagus, old person esophagus, and here we're seeing a corkscrew esophagus, which probably not only causes dysphagia but can also cause pain, because if you just try and imagine any of your muscles doing this, you could imagine that it would not feel good at all. So diffuse esophageal spasm and a corkscrew esophagus. So I have 6 minutes remaining, and we will see how far we can get through the tumors. I think I can probably make it. We will see, but I'll make sure I turn it over at the right time. So first, a little bit of background. In 20,000 consecutive autopsies, esophageal, there were 500 tumors, 82% malignant, 18% benign, right? So 80-20 rule always. Here, the 80 is malignant, the 20 is benign. So I show this slide because I start showing a whole lot of pictures of what turn out to be benign tumors. I never want you seeing a tumor and saying, Dr. Rosman told me this one was likely to be benign, and therefore I'm all good. Because the benign tumors and the malignant tumors can look exactly the same at early stages, and there's an 80-20 rule of them being malignant. So when you see something and you think that it's an esophageal lesion, you're going to get a scope. Repeat after me. When I see something, I'm going to get a scope. And then you can then try and pontificate about what exactly it's going to be. So in the benign, they can be mucosal, which is less common, or extramucosal, which is more common. So again, you see an intramucosal, you see a mucosal lesion, right? First, 80-20, it's cancer, and of the benign, it's more likely that mucosal is less common to be benign in that first place, right? So papillomas and adenomas are the big ones, and then with the differentials of a malignant polypoid tumor, air bubble, foreign body, and varix. The air bubble in there I put because, you know, it's the whole idea of one image is no image in fluoro. You need to be able to have enough time to see whether or not that thing moves. So here we have an exam, and again, here in the distal esophagus, you have something. You have another something here, right? And one of those could be an air bubble, or both of them may be real lesions. Here's another lesion. This one doesn't look so much like an air bubble because you can see some irregularity to it. So what's going on here? We have, it's a squamous papilloma. Now, how do I know that it's not a squamous cell cancer or a papillocarcinoma? I don't, and therefore I'm going to get a scope. But this is what a papilloma looks like. And this is what papillomatosis looks like. It is also what it looks like when you give the patient fizzies and then they burp while you're trying to do an exam, and up comes all of the gas. And so again, this is squamous papillomatosis, but you want to make sure that you take multiple images and show that disease process. And so here is squamous papillomatosis and the lung findings as well that go along. So those are the intramucosal benign. The mucosal-based benign lesions. If we go to the extramucosal, you'll see, right, that they have this extrinsic appearance, right, and it looks quite different, right? This looks more like the effect that the aberrant subclavian had on the esophagus, right, because it's an extrinsic pressure. Here again, extrinsic mass. And you can see it here. So here's leiomyoma. You can see again, like I described earlier, the dysphagia aortica and the Pac-Man bite. It's the same thing. It's extrinsic power out of extrinsic impression on the esophagus. So here again, in submucosal leiomyoma, extrinsic. Here are multiple of them. So again, you can see all the extrinsic effect here of multiple leiomyomas. And occasionally they can calcify. What are you going to do with these? You're still going to get a scope. This is quite a different process. You can see that there's something that almost seems as though it's within the esophagus and it's displacing things from within. It's not mealtime. I don't know whether or not you are eating your lunch while watching this, but this is a fibrovascular polyp, usually in older men. They're in the proximal 1/3, and what happens is it's a fibrovascular core covered by squamous epithelium, and they get longer and longer and longer because they're within the esophagus, and they get milked down to be longer and longer. So here's a 53-year-old woman with a sudden onset of chest pain, and it sort of looks like that fibrovascular polyp, but you can just see that there's something that's very irregular and sort of filling the wall of the esophagus. You can see what looks like a wide border here, and here what looks like a long stricture, right? And so maybe this is that prolonged as acute pain, so it obviously isn't. And what is this? It's a hematoma, and you can see the fluid levels within it, and they're spontaneous, and then you've got these people are going to the OR. Here are more examples of an extramural, an intramural cyst, extramucosal lesion. And I am going to stop there before getting to the malignant esophageal tumors. But what I will tell you is, remember, whenever you see any of those things in the esophagus, you want to be thinking about scope sooner rather than later. You, even though you might believe that there's a squamous papilloma and a squamous papilloma is benign, that could just as easily be a squamous cell carcinoma of the esophagus, and therefore you know that you're going to get a scope. And with any of the other benign findings, the non-tumor findings that I put in the beginning portion, remember the GE junction is where the money is. You want to evaluate the entire esophagus, but make sure that you do so broadly. And then lastly, I would say that when you make that finding, use your esophagram as sensitive rather than specific. You should know what you think that it is, but ultimately make sure that you end up getting the scope, because you are going to do the patients more of a favor than you would otherwise. So with that, I will turn it back to Dr. Betty, and I very, very much appreciate your attention.
Thanks so much, Dr. Rosman. Really, really appreciate your talk. Grateful for your time. We know how busy you are. We really appreciate it. So with that, I'd like to invite Dr. Robbins to begin your presentation, please.
It's a pleasure to be here. I'm glad that all of you are here joining as well. We're going to turn our attention from the top half of the body to the lower half of the body and spend some time talking about cervical cancer, how we diagnose it and stage it with imaging, treatment planning, and post-treatment monitoring. So at the end of this presentation, I hope that you'll understand why the changes were made between the 2009 and 2018 FIGO staging classification for cervical cancer. I hope you'll be able to apply the new staging system to images to be able to assign the appropriate stage to a cervical cancer case and recognize disease recurrence. So why do we care about cervical cancer? It's the fourth most frequent cancer in females. There are nearly 600,000 new cases per year as of 2018. And 90% of the deaths of cervical cancer occur in low and middle income countries. So this is a pretty big problem. The International Federation of Gynecology and Obstetrics, or FIGO, has provided us with the staging system that we have used for many years. If you'll recall, cervical cancer is primarily a clinically staged cancer, given that most of the cancer occurs in developing countries. So for a long time, we used this 2009 iteration of the FIGO staging system. At the end of 2018, FIGO came out with a new staging system, which formally incorporated more advanced imaging to account for pelvic lymph nodes specifically, and had some other more fine detailed changes in stage 1B disease. So for the next few minutes, we'll focus on the changes in the staging system and why those changes were implemented. So this study looked at the overall survival of cervical cancer depending upon the size of the tumor. And you'll see that based upon tumor size, we have different survival characteristics over time. So these size criteria help to inform the subcategorization of the FIGO stage 1B tumors. When we look at survival itself, relative to stage 1B1 tumors, there's a 2 times increase in mortality for stage 1B2 tumors, those tumors that are between 2 and 4 centimeters in diameter, and there's a 4 times increase in mortality for stage 1B3 tumors, or tumors that are greater than 4 centimeters. So this difference in survival based upon the size of the tumor informed the change from 2009 to 2018 to further subdivide 1B1 tumor, or 1B tumors into 1B1, 1B2, and 1B3 tumors. Lymph node status is another pre-treatment predictor of progression-free and overall survival. When we look at 2-year disease-free survival, we see that if patients do not have pelvic lymph nodes, they have an 84% chance of a 2-year disease-free survival, and that 2-year disease-free survival drops to 50 to 60% if they have positive pelvic lymph nodes. If patients have para-aortic lymph nodes, the 2-year disease-free survival is much more grim, with only a 13 to 41% overall 2-year disease-free survival with positive para-aortic lymph nodes. And it turns out that the presence of para-aortic lymph nodes is the strongest predictor of survival. And this is so important, I'll show you again. Para-aortic lymph node status is the strongest predictor of overall survival in the presence of cervical cancer. So this is perhaps from a radiologic perspective, one of the most relevant changes to the staging classification between 2009 and 2018, in that the lymph nodes in both the pelvis and the para-aortic regions are finally given some credibility. Before 2018, the lymph node status was irrelevant because the developing countries had little access to more advanced imaging techniques. And since that lymph node status is so impactful on the prediction of long-term survival, the lymph node status has been incorporated into the 2018 FIGO staging system. So one more time, this is what the 2018 FIGO staging system looks like with its most recent update. So how do we apply this staging system to our image interpretation, and how do we use the staging system to inform the types of information that we communicate in our reports? So let's start by assessing the presence and the size of the tumor. I direct my attention first to our T2 weighted images. I think we get a lot of information on the T2 weighted images. The native cervical stroma is very dark on T2 weighted images, and the tumor itself has an intermediate T2 signal. We also look at contrast enhancement. Diffusion weighted images are essential to help define exactly where the tumor is, particularly with respect to parametrial invasion. And PET is often obtained concurrent with MR for staging of the entire body. So when we're identifying the tumor, as I mentioned, my first stop is with T2 weighted images. And as I mentioned, the tumor itself is intermediate in signal relative to the dark T2 signal of the normal cervical stroma. So in the sagittal plane, we see the normal cervical stroma posteriorly, and in the axial plane, we see this ring of dark normal cervical stroma surrounding the intermediate T2 signal intensity tumor. After contrast, the cervical tumors are relatively hypoenhancing relative to the remainder of the cervix and the myometrium, and they restrict diffusion on DWI sequences. In the case of very small cervical tumors, diffusion weighted images help confirm where these tumors are. On the next slide, I have annotations. I'll just give you a moment to look and see if you can identify the tumor on this T2 weighted image. Again, I'll remind you that the dark stroma is normal here. This is a Nabothian cyst. And then there's this subtle, very subtle T2 signal alteration here on the right side of the cervix. And when we compare this to our diffusion weighted images, we see that on the high B value image, there's restricted diffusion corresponding to this area. So this is a very small cervical tumor. We can also confirm the presence of the tumor with a concurrent PET, and we see intense metabolic activity corresponding to this lesion. So I mentioned the size of the tumor informing the stage for 1B tumors. So how is it that we identify which measurement to use? For the assessment of the tumor size, we are using the longest axis of the tumor. So what you could do is measure the tumor in all three planes and select the longest measurement. This particular tumor measures 2.5 centimeters, which makes it a stage 1B2. Here's an example of a patient who had squamous cell carcinoma of the cervix diagnosed by biopsy. The biopsy specimen showed invasive cancer up to a maximal depth of 5 millimeters. There was no lymphovascular invasion, and this is what our MRI looks like. We see this small biopsy defect, and we aren't able to appreciate any residual mass. So this puts us in the microscopic size tumor, the 1A category, and since it's 5 millimeters in maximal depth, this is a 1A2 tumor with no radiographic residual tumor. So once you've identified the tumor itself, the next step is to assess the extent of the tumor. We routinely use vaginal gel, and I'll show you why in a few slides coming up. We use the T2 weighted images. I love the T2 weighted images without fat set for assessment of the parametria and involvement of the pelvic sidewall. And we use our contrast enhanced images. So here are two different patients with cervical tumors, and we see vaginal gel within the vagina. The vaginal gel distends the vaginal soft tissue for a couple of reasons. One, it moves the vaginal soft tissue away from the tumor itself, so we really get a better sense of the margins of the tumor, and it allows us to assess for involvement of the vagina. So the cervical tumor on the left-hand side of the screen here is confined to the cervix itself. And on the right-hand side of the screen, we see that tumor is involving the upper 1/3 of the vagina. So what about perimetrial invasion or stage 2B tumors? So as I mentioned, I really like the T2 weighted images without fat sat. I love the bright signal of the native pelvic fat and the contrast that it gives us between the tumor itself, the normal cervical stroma, and the perimetrial vessels. So when we're trying to assess whether or not there's perimetrial invasion, we really want to look for this native dark T2 signal of the cervical stroma, and we look for disruption of that cervical stroma by the intermediate T2 signal of the tumor. As we can see posteriorly, we've got thin cervical stroma along the lateral aspect of the tumor posteriorly, but there's a disruption of that cervical stroma posteriorly. We look for encasement of the perimetrial vessels. So the perimetrial vessels are these flow voids. And in this instance, we see this intermediate T2 signal of the tumor encasing the vessels and surrounding the vessels. So we know that there's no normal perimetrial fat left around these vessels. And finally, we look for a bulge in the contour. If the tumor is completely confined to the cervix, it usually will have smooth, round margins. If it starts to extend beyond the confines of the cervix into the perimetrium, we often will see a bulge in the contour. After we've identified what we believe to be tumor, we do want to confirm with our DWI images to make sure that all of this intermediate T2 signal that we see on the T2 weighted images, in fact, is restricting diffusion and corresponding to tumor. So we can trace the margin and see that we have this focal bulge along the left side, and all of this intermediate T2 signal corresponds to restricted diffusion. Ureteral involvement puts the patient into a stage 3B category if we have involvement of the ureters or the pelvic sidewall. If we see dilated ureters or hydronephrosis, this implies that there is ureteral involvement. We don't always see the tumor itself, but if we've got hydronephrosis, then that implies that we have ureteral involvement and we're stage 3B. We can look for hydronephrosis on the axial T2 weighted images, as we see here on the right. We see a dilated right ureter. I really like using this large field of view coronal T2. Sometimes you can get away using your 3-plane localizer, as it confirms that you're seeing in the dilated renal pelvis at the level of the kidney as well. And here you can see this large cervical tumor that's involving the distal ureter as well as the urinary bladder. Stage 4A disease is defined by a disease that involves the adjacent organs, particularly the mucosa of the bladder or rectum. So again, we're going to start with our T2 weighted images. We're going to identify where the intermediate infiltrative T2 signal is of the tumor itself. I've labeled with a V the bright signal from the vaginal gel, and C here is the normal cervical os. And posteriorly, we see the rectum. This ill-defined infiltrative T2 signal involves the anterior wall of the rectum. And after we give contrast, we have confirmation that the enhancing tumor is involving this right side of the rectum, extending all the way to the lumen of the rectum. And we see some of the normal rectal wall to the left side. Similarly, with bladder invasion, we start with our T2 weighted images. We can see the tumor indenting upon the posterior wall of the urinary bladder. The contrast enhanced images can confirm that the mucosa is enhancing and is also abnormal, sometimes just with mass effect. we can see the tumor pushing on the bladder, but with contrast, we don't see actual invasion into the bladder. So the T2 weighted images and the post-contrast images can be complementary in identifying rectal and bladder invasion. If we're uncertain whether we're seeing mass effect of the tumor upon the posterior wall of the bladder or whether we actually have invasion to the mucosal surface of the bladder, we can recommend cystoscopy. And in this case, we see this bulge along the posterior wall of the bladder corresponds to some edema, but also some invasive cancer. Other examples of invasion of adjacent structures include this case where we have invasion of the urethra. The urethra should be a normal, the normal urethra should be sort of a donut shape structure. This person has a Foley catheter in place, but we should see this donut of T2 signal surrounding the urethra. And in this instance, we see this intermediate signal of the tumor replacing the left side of the urethra. We have no normal urethral musculature. We also, posteriorly, we see some of the normal vagina on the left, and we see tumor extending into this lower portion of the vagina. So in this instance, we have urethral and lower vaginal invasion. Another example of a stage 4A tumor, we see this very large tumor replacing most of the cervix. We see extension to the posterior wall of the bladder. And on this post-contrast image, you can see that the abnormal enhancement extends to the mucosal surface of the urinary bladder, confirming bladder invasion. We see abnormal T2 signals surrounding the urethra that also enhances, and we've got extension into the lower portion of the vagina. So lymph node assessment is our next step after we've identified the tumor, both the size of the tumor and its local extension. For lymph node assessment, again, we use our T2 weighted images, our contrast enhanced images, diffusion weighted images, and we can compare with the concurrent PET, either PET CT or PET MRI, or occasionally patients will have a staging CT to include the entire abdomen. As a reminder, we want to know whether the patient has pelvic or periaortic lymph nodes, and if you remember, it's these periaortic lymph nodes that confer the worst prognosis for these patients. So on our T2 weighted images, we're looking for intermediate signal lymph nodes that enhance, and the lymph nodes restrict diffusion on our diffusion weighted sequences and have metabolic activity on the corresponding PET. This is an example of a patient who had a concurrent PET MRI. When we read the diagnostic MRI of the pelvis, we did not identify this deep iliac lymph node, but the lymph node became more conspicuous at the concurrent PET, which upstaged this patient from a 2A to a 3C1, stage 3C1, because she had this positive pelvic lymph node. Periaortic lymph nodes are just like any other periaortic lymph node. We can see bulky periaortic adenopathy on CT, on PET, or on our MRI, depending on the field of view that we've gotten for our pelvic MRI. One of the important things for the surgeons and the radiation oncologists to know is the cephalad extent of the periaortic lymph nodes, and that left renal vein, we're just below the left renal vein here. That left renal vein is an anatomic landmark that's important for both the surgeons and for the radiation oncologists. So if you identify periaortic lymph nodes, you might want to describe the relationship of those periaortic lymph nodes to the left renal vein so that the surgeons and the radiation oncologists can plan accordingly. I won't spend a lot of time talking about assessment of distant metastases in cervical cancer is basically just the same as metastases in from any other primary malignancy. So we can see it on PET or on routine CT as well. So again, one more look at the 2018 FIGO staging system of cervical cancer as a reminder for the things that we're looking for. So now that I've walked you through how to assess cervical cancer with imaging, I'd like to spend a little bit of time talking about the different treatment options and how our description of the tumor will impact the treatment decisions and the treatment options that are available to each patient. So there are three main categories of treatment for cervical cancer, and they include surgery, concurrent chemoradiation therapy, and systemic chemotherapy. Many of our cervical cancer patients will be young, so there are a few fertility-sparing options for select patients, and they include cold knife conization, or cone, or a radical trachelectomy or a cervicectomy. Which patients would be eligible for conization? These are going to be the patients that have microinvasive disease, so those patients that have disease that are diagnosed based upon a biopsy, but there's nothing by imaging and there's nothing visualized, so the stage 1A patients. If you're like me, you didn't know what a cold knife cone looks like, or a LEAP, that's another minimally invasive surgical procedure you may have heard of. So I included these graphics just to give you a sense of what it is that the surgeons are doing for these procedures, and it might make some of the post-operative or post-procedural changes of the cervix make a little bit more sense to you. So with a cold knife cone, a scalpel is used to take basically a cone-shaped sample of the inner cervix, and with a LEAP, electrocautery is used to kind of scoop out the abnormal portion of cervix. Trachelectomy or cervicectomy is where the distal aspect of the cervix is removed and the rest of the uterus remains in place. Patients that are eligible for trachelectomy are, again, patients that have early stage disease. Most commonly, it's for patients with stage 1A2 and 1B1 tumors, or tumors that are smaller than 2 centimeters. There are a handful of centers that will consider patients that have slightly larger cervical tumors for trachelectomy. So this will really be dependent upon your local surgeons. If the patient is going to be a candidate for trachelectomy, they need to have at least 2 centimeters between the cephalad margin of the tumor and the internal cervical os so that they can maintain cervical competency. And this is sort of the diagram of what that trachelectomy looks like. The dotted line indicates the portion of the cervix that's removed, and at the completion of the surgery, they often will have a cerclage in place. So if you're reading an imaging study for a patient that may be eligible for trachelectomy, how do you let the surgeon know what the margin is? First, you're going to identify the margins of the tumor itself. You'll identify the internal cervical os, and you'll measure the distance between the internal os and the cephalad margin of the tumor. And again, remember, they need to have at least 2 centimeters of distance to consider the patients for trachelectomy. Patients who are eligible for hysterectomy are those who have invasive cancers less than 4 centimeters in size. And patients who have larger tumors or who have locally invasive tumors are eligible for radiation therapy. I'll spend a really brief moment talking about radiation. Patients who have radiation therapy for cervical cancer undergo both external beam radiation, which shrinks the primary tumor and treats microscopic disease within the pelvis. And here's an example of what happens to these tumors after external beam. We've got a large primary tumor, and after just 1 month of radiation therapy, that tumor has melted away to nearly nothing. The second component of radiation for cervical cancer is brachytherapy. This is where we have a hollow catheter that's placed within the cervix, and point source radiation is administered through that catheter. And the goal of brachytherapy is to treat the residual disease and soft tissues after the external beam radiation. So in our last 5 minutes, I'm going to talk about what these patients will look like after they've had treatment, whether it's surgery or radiation. So our expected treatment response, as I sort of alluded to a few moments ago, is that we should see the tumor melt away with radiation. So this is the same patient before treatment. We can see her infiltrative tumor in the cervix. There's perimetrial invasion on the left, so she was a candidate for radiation. And this is what she looks like after radiation. We see that there's resolution of the primary mass. We get return of this hypointense T2 signal of the cervix. And there is still some residual architectural distortion where we had that perimetrial invasion from, and that architectural distortion is from the scarring from the radiation. Here's another example of a patient with an extensive tumor that's really kind of infiltrating through much of the uterus, involving the base of the bladder, probably the urethra and the pelvic sidewall. After radiation, again, we see that tumor has almost completely melted away. The T2 signal of the cervix has returned. The uterus becomes atrophic, and we lose that differentiation of the myometrium and endometrium. Patients who have a history of hysterectomy for cervical cancer are at risk for having a vaginal cuff recurrence. If we suspect vaginal cuff recurrence, we're looking for T2 signal alteration in the vaginal cuff itself. In this particular patient, we were very suspicious of a cuff recurrence. There was a little bit of fullness, but she had new hydronephrosis. We like to have vaginal gel in these patients to really characterize the vagina itself. This patient, for some reason, did not have vaginal gel. Here's an example of a patient who did have vaginal gel and how that really allows us to better delineate where the tumor is itself. This vaginal gel gives us contrast between the lumen of the vagina and the soft tissue mass of the vaginal cuff recurrence. As I mentioned, that after radiation, we should see return of the hypointense signal of the cervix itself, and we should always be suspicious if we have return of this intermediate T2 signal in the cervix after the cervix has gone back to a more normal appearance after radiation. And this can be confirmed with diffusion-weighted imaging, and the recurrent cancer will show restricted diffusion. We have expected post-treatment findings after radiation. Patients can develop radiation cystitis, bladder wall thickening, enteritis, colitis. We see a lot of soft tissue edema in the pelvic soft tissues. One thing you need to be aware of is that if patients have pelvic radiation, occasionally they will have transposition of their ovary from their pelvis up into their abdomen to maintain some of their hormonal function. So you need to be aware of this when you're reading a follow-up CT. This was initially called a cystic mass, but if we look more closely, we see surgical clips, and this is merely a follicle in a transposed ovary. Necrotic lymph nodes can evolve over time. So at our baseline, we see this necrotic pelvic sidewall lymph node that involudes over time, and we have to be aware that the reverse can happen. So after 6 cycles of radiation, we see what looks like an ovary, but when we look at our baseline CT, we see that this was a solid mass, and we have to recognize that this is a lymph node, as it is lateral to the pelvic vessels rather than medial. The ovary tends to sit medial, and lymph nodes are lateral. So this is a lymph node that underwent cystic necrosis after radiation treatment. We've got extensive pelvic recurrence in this particular case. Here we have a patient with a tumor that extended from the vagina through into the rectum, and post-radiation she developed a rectovaginal fistula. And finally, this patient underwent treatment for cervical cancer 3 years ago and presented with this brain MR after a fall, and this was biopsy proven to be cervical cancer metastasis. So in summary, the FIGO staging system was recently updated at the end of 2018. Hopefully you will be able to take a look at pelvic MRs and have a better sense of what sorts of things to report upon for accurate staging based on imaging. Thanks so much for your attention today.
Thank you so much, Dr. Robbins. We really, really appreciate your time, and the comprehensive talk. Thanks everybody for attending, and we'll join up with you again next week on Tuesday. And have a great weekend and be well.